Medurstand. Understanding medicine.
I'm Professor Aziz-ur-Rehman, and this is the second of the series of lectures on endocarditis. In our previous lecture, we discussed the definition of endocarditis and the pathophysiology of endocarditis, classification of endocarditis, and then the diagnosis. The most important part was the diagnosis, and then, of course, diagnosis is one component of the management. Then we have to proceed with the treatment, and this time we are going to focus on the treatment of endocarditis. Uh, First of all, I would like to highlight some basic principles of antibiotic therapy when it comes to endocarditis. So these features are: number one, I think these patients should be treated in the hospital because the treatment is very demanding. Many times patient would need 4 times a day injection and other care. So I think it is best that patient is admitted to the hospital, or hospital-like care is provided at home in some nursing care home or patient's own house. So some nurse or some doctor should visit to make this treatment possible. So intravenous treatment is usually done. So, and the second very important principle of the management is that we must draw 3 samples of blood for culture and sensitivity, send them, and only then start treatment. And the treatment would be based on our empirical judgment. Empirical therapy means that the choice of antibiotic would be based on our best guess, and the best guess would be based on the patient's condition, the setup in which patient develops endocarditis. Of course, we suspect endocarditis very strongly, but we will give antibiotic only after we have sent the sample for culture. Now, there may be another situation, that is the patient has already started taking antibiotics. Somebody started antibiotic for some other condition or for just fever. And I think it would be very important to stop antibiotic and give an antibiotic free period of like 72 hours and then draw 3 culture over a period of 12 hours and then start antibiotic. Waiting that much is actually less risky than giving an antibiotic which might not work. So this is the principle number 2. Then third thing is that the antibiotic must be, or at least should be, bactericidal. Bactericidal is an antibiotic which actually kills the bacteria. And parenteral, because we need to have high plasma level. You know, these vegetations, they do not have any circulation. So antibiotic will not reach the depth of the vegetation through circulation. It will only imbibe through the wall. So for that you need to maintain a very high level of concentration of antibiotic, and that will be possible only by giving a parenteral antibiotic. Although these days we have some antibiotics which are claimed to have the same efficacy if taken orally, but I think the traditional approach is that since these patients are very sick and we do not want to take any chance, so these patients should be given parenteral antibiotic, intravenously or in some cases intramuscularly. And the dosage used is high dose. In any antibiotic, like other medicines, we have a range of dosage. So in endocarditis, we must use the maximum dose recommended for that patient, for that weight, in that antibiotic. So that we want to we do not want to miss any chance. So I think we want to give him the best chance. The high dose antibiotic should be given. Then the antibiotic therapy is typically prolonged. By prolonged, I means it is typically 4 weeks. It's not just normal antibiotic 5 days or 6 days. It is about 4 weeks, and in some cases maybe actually longer. So most common causes of endocarditis would require 4 weeks therapy. So that is also important principle. Then the empirical therapy for suspected strep viridans or strep ficalis. These two collectively constitute the commonest cause of endocarditis, especially in those patients who had underlying valvular heart disease. So since there is no way to differentiate between these two, Strep faecalis or Strep viridans, it is not possible to differentiate between the two clinically. So we actually give a coverage which will for both. All right. So benzyl penicillin is a traditional antibiotic. 4 mega units is given intravenously 4 times a day for 4 weeks. So that is the dosage. Please do not underdose these patients because this is not an easy infection to be treated. Now we also add gentamicin or any other aminoglycoside in the recommended dose. In gentamicin, the recommended dose is 80 milligram intramuscularly. Some aminoglycoside can be given intravenously also. I think gentamicin can also be given intravenously, but traditionally it is given intramuscularly. So given 3 times a day for 2 weeks. The advantage of gentamicin is to cover Strep faecalis. Now, gentamicin alone does not cover Strep faecalis, and benzyl penicillin alone does not cover Strep faecalis. But when given together, then gentamicin will work. Why gentamicin alone does not work? Because it is an intracellular antibiotic. It has to get into the cell to be effective, and an intact cell wall of streptococci would not allow this antibiotic to enter the cells. But if the patient is taking benzyl penicillin, and you know penicillin, they work primarily on the cell wall and they will make the cell wall porous and weak, and this will allow gentamicin to enter the cell and cause its action. So this very intelligent synergistic action is used for the treatment of suspected Strep faecalis or Strep viridans. Both antibiotics are started after 2 weeks. 2 weeks, gentamicin is withdrawn, penicillin is continued. You know, gentamicin is an aminoglycoside, so we need to be careful about its side effects, ototoxicity, and nephrotoxicity. So you will observe the patient for any possible side effect. Now, the second situation is empirical therapy for suspected Staph aureus. Now, when do we suspect Staph aureus? There are a number of situations. One, patient just recently underwent some skin procedure, or patient had some skin infection, or patient just had some cardiac surgery recently, or has a prosthetic valve, or is intravenous drug abuser. So these are the patients who are likely to have Staph aureus. And there is another staph, which is Staph epidermidis, which is even more difficult to treat. And Staph aureus can be methicillin resistant Staph aureus, or it could be methicillin sensitive Staph aureus. Methicillin, you know, is a derivative of penicillin. So these would be relatively easier to treat, and penicillin based antibiotics will work, but this one would require different antibiotics. So I think before we receive the culture, we do not know which one. So I think it would be safer to assume that this is MRSA. So once you receive the culture report, then you can maybe switch over to the other option. For MRSA, methicillin-resistant Staph aureus, the best antibiotic is vancomycin. Vancomycin is given intravenously twice a day. The dosage is 1 gram twice a day, and this is to be given for 4 weeks. 4 weeks, no less. Okay, so vancomycin is expensive and toxic drug, so you need to keep an eye on the toxicity part. If culture report shows that this is actually methicillin sensitive Staph aureus, then ceftriaxone, which is actually third generation cephalosporin, primarily belonging to the family of penicillin, so ceftriaxone would be useful. This would be much cheaper than vancomycin and would also be better tolerated and widely available also. So 2 grams intravenously once a day for 4 weeks. Or the alternate choice would be 1 gram twice a day, but I think 2 grams once a day is good enough. Now, in cases where you do not know for sure which organism, I think making a combination of these two would make some sense to me. So this is when we suspect Staph aureus. So this is the antibiotic. And third situation is some specific therapies. You remember in the etiology, we discussed some unusual organism, haystack bacteria, and fungi. Then, of course, the antimicrobial will be used according to the exact culture, and these culture typically take long time, and the exact choice of antibiotic and the duration will be dependent on the culture report. Sometimes we have to resort to the surgery also. The treatment of endocarditis may be surgery. Somebody who had prosthetic valve only recently got infected. This is very likely to be staph and staph epidermidis. So I think it is best treated by replacing the prosthetic valve. And other people who have developed abscesses in the heart, they have ruptured the valve chordae are ruptured, they might also need surgery. So surgery would be considered, I think, in fungal infection, because fungus can sometimes make a big ball. It's like a mass lesion present in the heart that also needs to be removed by surgery. So patient is already very sick, but I believe we cannot treat him with medicines. We need to do the surgery. Now, talking about the complications of this disease, there's some local complication and some systemic complication. Local complication, there may be damage to the valvular structure, the valve itself, or its chordae, or its ring. So any part of the valve may be ruptured, and that would of course lead to perforation. And this is the example. There's a perforation of valve that would result in regurgitation, and that is why you remember the Duke's criteria, the modified Duke criteria. The last addition was a new regurgitant murmur. Somebody develops a new regurgitant murmur during a febrile illness is one of the major criteria actually. So that is because of the rupture. Then these are the vegetation, they could be embolized, and this is the abscess, the cut section of an abscess. So abscesses are actually very serious complications because they could result in heart failure, and they could also cause conduction abnormalities. Now, abscess formation is another complication, cardiac failure. Uh, Infective endocarditis will not necessarily be restricted to the endocardium. It would affect muscle also, so it will reduce muscle contraction and may precipitate heart failure. These patients have already diseased heart, so further insult may precipitate heart failure, and then conduction abnormalities depending upon where this abscess is situated. It could cause AV nodal blocks or bundle branch blocks. So I think that is another local complication. Now let's move on to some systemic complication these patients can develop. Now systemic complication will be even more serious. First is the embolization. Now embolization from the vegetation or embolization from the thrombus. Since these patients have underlying valvular disease, they are also prone to have ordinary type of thromboembolic phenomenon. A thrombus may be formed in the atrium or atrial appendage that might get dislodged and go anywhere and cause ischemic necrosis. Like in this patient, it is gangrene. And then sometime patient may just some small vegetation can dislodge, can detach itself from the endocardium. What is a vegetation? It's a small structure consisting of platelets, fibrin, and microorganism. So wherever these small vegetations go, they may not cause a significant ischemic damage, but these vegetation will settle there and will establish infection. And ultimately, patient would develop an abscess. Say, for example, if these vegetation go to the brain, patient will develop brain abscess. Or they could actually go anywhere. They could go to the bone, resulting in osteomyelitis, could go to the spleen, resulting in splenic abscess, things like that. So there would be systemic embolization. Then immune complex disease. In response to this common infection, one can develop immune complex disease like glomerulonephritis or septicemia. Septicemia is a condition where there is circulating toxins, bacteria, and many other organisms. They cause a lot of bacteriological effects and immunological effects, ultimately leading to what we call septicemic shock, a very serious condition. If a patient with endocarditis is not treated properly, that patient could end up in septicemia. And of course, septicemia can result in death. Any of these conditions can also result in death. So endocarditis is a very, very serious condition. It needs your fullest attention, your fullest expertise to save these patients. We always talk about prevention. Prevention is, of course, better than cure. And you just must have realized how difficult is the treatment in these patients. So it is best if we can prevent these infections. There are 2 or 3 preventive strategies. One is if somebody has this valvular disease and is prone to develop endocarditis, that patient may be offered an antibiotic which is started 48 hours before the procedure and to be continued for at least 48 hours after the procedure. The theory behind this is that these patients already have a predisposing. You remember 2 conditions are to be met. One, the turbulence of flow. These patients already have. The other is bacteremia. So they already have one condition. The other condition of bacteremia is likely to occur when they undergo the procedure. So once that procedure occurs, there is likely to be endocarditis. So before any procedure is done, like dental extraction, like colonoscopy, like gastroscopy, so things like that, and some vaginal procedure, some skin operation. So whenever these procedures are done, or even any surgery, antibiotic is offered. These antibiotic must be the same which we use for the treatment. In high dose intravenously given 24 hours before starting the procedure. I must mention it here that some studies have indicated that these prophylactic antibodies, they do not necessarily prevent these infections. They have actually stopped giving these prophylactic antibodies, but in my opinion, doing is better. So I think we must try to prevent infection. If it still occurs, then we will of course deal with it, but giving prophylactic antibiotic makes a lot of sense to me at least. Then intravenous drug uses, these patients should, I think, ideally be counseled, and they should be taken off this bad habit of intravenous drug use, and they need, of course, medical attention, social attention. But at least something we can do is that we can provide them clean needles and syringes and clean water, distilled water, so they can inject with the clean needles. So that will actually minimize the chances of endocarditis. And they must also be taught not to share needles. They actually share needle out of desperation because they don't have, I'm sure if they have ample supply of clean needles and water, they would not share. Then one is avoidance and proper care of indwelling catheters. Those catheters, they may be necessary, but if they can be taken out, that will be very good. And whatever care has been advised to prevent infection, I think that must be followed. So these are some of the strategies we can prevent this serious infection. So this was it about the treatment. This was a brief account because treatment of endocarditis actually depends on the organism, and we did not cover those rare haystack bacteria and other bacteria, fungi, because then that will be beyond the scope of internal medicine. But do remember that this is a serious infection and we must do whatever we can to prevent this infection. And this was the second and the last lecture in endocarditis. This is Professor Aziz-ur-Rehman from Medurstand. Thank you.